everyone. Welcome to today's episode of Zip Chat. We're about ready to start. I'm going to go ahead and introduce Mike Watson, our host of today's Zip Chat. Mike, over to you.
Thanks, Jill, and welcome everyone to today's Zip Chat. Today we're going to be talking about AgeTech and how that might be able to move us from SickCare, which we're currently dealing with, to maybe a true HealthCare. With me, I have Arlen Myers. He's the president of the Society of Physician Entrepreneurs. Thank you for joining us. I also have Craig Hillman. He's a senior VP at GateBetter. Craig, thanks for joining us. And also Lauren Reese here from Excellarate. She's our, I believe, Chief Solution Officer is that title, CSO. So welcome, panelists. Let me jump in by saying, telling you a little bit about what we hope you get out of this session. So one, we want to make sure everyone understands why healthcare maybe isn't healthcare. Maybe it's something different right now. Two, we want to make sure that everyone understands, in particular with aging population, seniors, some of their issues like the fear of falling and the failing of cognitive abilities and how that affects solutions going forward. What's the barriers to moving away from what we're doing now to something better? And ultimately, we'll discuss a little bit maybe how we can overcome those barriers. That's the context of today's discussion. I hope everyone enjoys it. Let's jump into it. So, Arlen, why don't you give us a brief idea of why it's SickCare? Like, why is it not healthcare?
Sure, and thanks for having me on this panel. So just a couple of facts. The United States spend on taking care of patients is approximately 4.2 trillion with a T, $4.2 trillion. It's the most money any industrialized country spends on it in the world. The problem is that if you look at Medicare and government insurance data and commercial data, about over 90%, in some instances 95% of that money is spent taking care of sick people, not making people healthy. So that's why I refer to it as SickCare. The second point is that the SickCare system, we refer to as a healthcare system, is really a SickCare system of systems masquerading and portrayed as a healthcare system. So whenever you hear people or elected officials or anybody talking about a healthcare system, that's really not what it is. And part of the reason, and the third point is, the system, and it's that way in part because every system is exquisitely successful at getting what it was designed to do. And in this particular case, people get paid to take care of sick people, not keep people well. So that's why I refer to it as a SickCare system of systems, or SickCare.
Yeah, that makes sense, and certainly my experience. Next question is, you brought to our attention this idea of planning horizons. Can you talk a little bit about planning horizons and how, and basically to set the tone for the rest of the discussion, because I think these planning horizons are interesting and can help us kind of focus on where we can move forward from there.
Right. So this notion of the 3 planning horizons is something that's been popularized by the consulting firm McKinsey, which I think most people at least heard of. Essentially, what it describes is what they refer to as the now, the next, and the new. So if you're in a position of doing strategic thinking or strategic planning, essentially what you're doing is, what do we do now? What do we do next? Which means for most industries, how do we take a product and create new markets? Or how do we take a market and create new products to grow the revenue of the company? That's the general strategy. And then, so when you go from the now to the next, you get incremental improvement in revenue if it works. But the new is, how do you make that model obsolete before somebody else does? So in the care of sick care, in the case of sick care, what, in terms of moving it from healthcare to sick care, sick care to healthcare, what do we do tomorrow? Or what can the audience do after listening to this presentation today? And fill in sort of any time you want. Is it a month? Is it 2 months? Is it 3 months? Is it a year? Then how are you going to migrate to the next? And then finally, which is a more long-term and challenging solution, is how do we make the present system obsolete such that we move it from sick care to healthcare?
Yeah, that makes sense. And I think if everyone is kind of getting their head around that, that'll help you when we navigate through the rest of this discussion. Thanks, Arlen. So Craig, you're a company that's working in the healthcare space, and you're sort of addressing these things in your roadmap and how you're moving forward. Do you want to talk a little bit about how your plans at your company are mapping to this now next new concept?
Sure. Thanks, Michael. I'd love to say that we were inspired by Arlen because his kind of vision kind of aligns with our execution, right? And obviously takes kind of both strategic and tactical to make change within a system like U.S. healthcare system. But unfortunately, I met Arlen a couple of weeks ago, so we'll just say we kind of, the stars have aligned. Yeah.
Yes.
Nothing
Right.
new under the sun. Right.
But right, so our technology kind of really fits within those concepts. So our technology, which I think the best way I heard somebody describe it is, it's literally a virtual obstacle course. The basic idea is we use semi-immersive virtual reality, so not the goggles, but actually just the TV. We use this semi-immersive virtual reality concept to bring what we call combined or simultaneous motor cognitive training to anybody who uses a treadmill. And it sounds relatively simple in concept. It's very powerful in practice, but what's great is it really kind of kicks on or touches a lot of the things that Arlen's talking about in terms of sick care versus healthcare, and the now, the next, and the new. And let me just kind of give you a couple examples. So the main purpose of GateBetter is really to put a significant dent in this massive epidemic we have among older adults, which is falls. Something like almost 30% of older adults fall every year. A significant portion, I believe it's like 800,000 to 1 million, go to the hospital, are actually admitted to the hospital because of falls. And there are significant problems in terms of, I guess, acute issues in terms of concussions, brain injury, hip fractures, all due to these falls. So we know from lots of longitudinal studies that really the key driver for falls is not necessarily vestibular or balance. It's not physical issues like muscle strength or even like abnormal gait. It's really cognitive. We have this specific type of cognitive decline as we get older that affects specifically our executive function. And that's what causes our problems in terms of falling. Specifically, we have a reduction we call motor cognitive reserve. So that using these semi-immersive virtual reality combined with a treadmill, we can literally retrain the brain, right? So when we identify these people who are, as Arlen indicated, sick, right? They have fallen, they've been identified as a fall risk. We can be very kind of reactive in treating these people so they don't fall again, right? So it's 15 sessions on the system for only 30 minutes. It's really much more effective and much shorter than other fall interventions because the other fall interventions don't really address the key root cause for falls. So we're doing kind of what Arlen talks about what we currently do within the system, because in order for technology to roll out and have an effect, it needs to fit within the existing confines of the system. So that's the now. But really, there's nothing stopping people from using GateBetter as real healthcare. That is, something like 50 to 75% of the people who fall were actually never identified as a fall risk to begin with. So we really need to treat a broader range of the older adult population out there. We need to be proactive with them. In addition, there are kind of even underlying issues that we don't really always catch because people don't always reveal kind of the health issues that they have. A great example is if somebody decides that they're nervous about falling and are too embarrassed to tell anybody, what do they tend to do? They tend to become shut-ins. They stay on the couch, they don't go out. So we know that there are significant additional health issues with people who are not willing to walk, right? And we know, for example, if they don't interact with other human beings, we see cognitive decline. They don't get off the couch. We see kind of other physical health issues, heart issues, even increased cancer risk. So there's real opportunity for prevention, and because the system in some situations can pretty much be self-administered, it can be healthcare in a way that is doable. Doesn't require high cost resources. It's really can be implemented in a broad range of environments. So that's kind of the next, right? But we want to be even more proactive, right, with our healthcare. We want to identify people who are at risk. So we know almost all older, we have people who are falling, that's the now. We know a very large population that's in some respects always at risk, that's older adults and falling. And then we have people, we want to kind of get even deeper and identify that population that might be at risk before we know they're at risk. And that goes back to this whole concept of motor cognitive reserve. We all have motor cognitive reserve. We have different levels of motor cognitive reserve, and that actually can influence us in terms of our susceptibility to have cognitive decline due to certain neurological conditions or diseases like Parkinson's and Alzheimer's. So by getting on the Get Better system, experience kind of the same kind of virtual obstacle course, but us tracking your performance, we can actually get much closer to the possibility of measuring that motor cognitive reserve in a relatively accurate way and providing indications to you and your doctor that you in particular might need to be a little more proactive with your health to avoid those neurological indications being as severe as they are as you get older.
Yeah, that's really interesting. And it does definitely fit the framework quite well. And it's a great application of technology to solve real world problems in my mind. So I really like what you're doing there. And thanks for sharing with everyone so that we can get that example out there. So moving forward a little bit. So Arlen, question back at you. So this moving from, making momentum against this, very well entrenched system looks really challenging, right? And I'm sure there's a ton of obstacles. Can you let us know what you feel the key obstacles are?
Yeah, there are several barriers. Probably the most prominent one has to do with just the culture of medicine and the resistance to change from all the stakeholders. So that really, to me, seems to be the biggest one. And then the question is, well, and there's a whole list of them, but we don't have time to go through it. But so in my view, again, there are several solutions to this, but for me, the top of mind ones have to do with collaboration and breaking down innovation silos, because everybody sort of has their own place sandbox and they don't play nice with each other. So the first is you have, whether that's a data scientist, a healthcare professional, a vendor, a politician, I mean, the stakeholder list, patients, goes on. And we simply just don't play nice together. And so we need to do a better job of collaborating. The second is part of that means that you have to be culturally competent. And I don't mean you know how to get along with someone who looks different than you. I mean that's important, and that's informing the diversity, equity, and inclusion conversation. But what I'm referring to really has more to do with cognitive diversity. That means, how do people in different industries and different parts of the ecosystem think and feel about certain things? And there are certain segments of that. For example, every hospital, I'm an ENT surgeon. I've worked in many, many different kinds of hospital systems: safety net, VA, academic, private practice, community hospital, and the Indian Health Service. And every doctor knows that each hospital has its own culture. The culture of an academic medical center is very different than the culture of a safety net hospital. So you have to sort of be able to understand the differences in those subcultures in order to get along and facilitate interaction and collaboration when it comes to innovation. So I call these sort of the 4 C's. So the first is collaboration, the second is culture, the third is Congress. since SickCare is a highly regulated industry, and the most recent election is going to point that out, that if we are going to move SickCare to HealthCare, the rules have to change. And that is in large part geopolitically determined and typically colored red, purple, or blue. So we're just going to have to see how all that plays out, but you have to change the rules because the rules create ecosystems and business models. Without changing the rules, we're just trying to fit a square peg in a round hole. And finally, the fourth C is college. We have to educate undergraduates. Now, the argument goes, we should have entrepreneurial education in P through 20. And people in this audience probably have kids who are in preschool or in first grade that are learning artificial intelligence and coding. That's a step in the right direction. Or whether your kid is interested in engineering or science or STEM or STEAM or whatever you want to call it. But we need to, and particularly in graduate level, we need to do a much better job of changing medical education at the medical school, the postgraduate, the fellowship, and the early clinical training level so that people understand how to do this. And what I tell people is that it's cruel and unusual punishment to pay or threaten to pay healthcare providers based on value, so-called value-based care, without teaching them how to create it.
Makes sense. Yeah, so I think at the end, one of the things that I'm getting out of this is that this is not a problem that's going to be solved by the healthcare industry just wanting it to be solved, right? It's going to take it's going to take more than that,
Right.
Like
and I would add that I would add that SickCare cannot be fixed from inside. In fact, it's my belief and others that no industry can be fixed from inside. There has to be outside in, inside out, so-called open innovation to incorporate solutions that are available to solve what's going on in SickCare. Typical example is search. I mean, we have all these electronic medical records with all this information and doctors get burned out plowing through them. Google seems to have solved that problem.
Yeah. Yeah, and it also goes to the collaboration of data. Like we know, sharing as a patient, not as a physician or in the industry at all. I mean, it's very frustrating to have to fill out your forms over and over again, even when you're in a connected set of providers. So I mean, just something as basic as that is broken, let alone, like you say, what the doctor has to do to get all the information necessary to give the best potential outcomes or create the best outcomes. So thanks for that. So Lauren or Craig, anything you want to add to that list or any points you want to make in addition before we move on?
I don't think so.
Okay,
Arlen is very succinct and very insightful. I feel I would do a disservice by adding additional comments on that.
Thank you.
That sounds great. So Arlen, given what you just said, what can we do right now with the technologies and the processes and the regulations that are currently in place to make it even just a little bit better? What are your thoughts there?
Well, I think it depends on the stakeholder. Like if you're asking me, what do I think? I mean, my activity these days revolves around helping doctors and other healthcare professionals get their ideas to patients. So what are we doing now to grease that skid? So what we are doing, and it relates to what I just said, is we are reforming medical education. We, and I can get into the weeds, are reforming medical education to include medical and healthcare entrepreneurship. And I have taught these courses around the world, actually, to various medical schools. It needs to be, in my opinion, the ACGME, the American Graduate Medical Education, needs to include entrepreneurship and practicing medicine with a viable business model as a seventh competency. We don't hold residents accountable for learning the business and demonstrating that they know how to practice the business of medicine. And every single doctor I talk to, if you ask them, what should you have learned when you went to medical school that you didn't? The number one thing they say is the business of medicine. So we're fixing that. We're changing that. And we need to, but education is only going to get you so far. So we need to provide people with, in addition to education, resources, networks, mentors, experience, peer support, and non-clinical career guidance. And we are doing that. And then finally, so this is the progression from the now to the next. And then in terms of the new, the primary pressure point has to be Congress and the Hill. If you didn't vote, shame on you. And if you're not involved in some sort of initiative that trips your trigger, don't expect things to change.
Yes, that's a very good point. Change doesn't happen without us getting involved, I would say. We have to, one of the things that we talked about is, in order for us to make a change, us individuals, we have to take these initiatives and push them, whether that's through voting or whether that's through, the initiatives like yours, Arlen, where you're actually going out and reaching out and making a change through action. It's very much appreciated. So, Lauren, let's get you into this conversation. So we talked about value-based care, outcome-based care, and that's something that's kind of top of mind because the government, is creating regulations or whatever around that, trying to move that in the right direction, or maybe not. I don't know. I can't really value just that. But anyway, what do you think is possible in the now space with those changes in mind?
Well, that's a great question, Mike. Well, before I address it, I want to thank Arlen and Craig for their insights so far. I think that both of them really touched on some of the things that we can do now. And Arlen was talking about how value-based care exists and whether we have set that up properly. So, I think in the now, it's about getting access to the patients who need access and access now. I think there's a couple of things stopping us there, and the teams touched on it. It's really around aligning the stakeholders in the healthcare process. So, today, value-based care is talked about. I think tomorrow, and we'll talk more about it a little later in this session, tomorrow it's about making sure we know how to deliver value-based care and that the incentives that get us there are truly what will move us from SickCare to HealthCare. But in the now, right now, I think that, from a technology perspective specifically, it's about getting to the right patient in the right setting at the right time in their journey. And so, taking value-based care out of it, because I think we're too early in that process, we have some processes that exist today that can help us immediately in the current situation. So for example, taking health assessments and delivering them to patients in the right setting, bringing down the barriers to getting information about what the patient needs, like Craig was talking about. So many times we don't even know that a patient is at risk for falling because we're not assessing their needs early enough, or we're only assessing their needs in the situation where they've been identified as being sick or at risk. So how do we leverage, the now? How do we make sure that there are patient-centric tools around assessments that are assessing patients, and then building plans and processes from all stakeholders to deliver what they need? I think that's one big piece. The second big piece is, we put so many barriers to care sometimes. If you just look at, and maybe rightfully so to some degree, but we want to make sure that the patients get what they need. And if you just think about a process maybe like prior authorizations, right? And the need for health plans to receive prior authorizations to ensure that patients get the right care and that there's some gating process around that. So today, that process often prevents patients from getting care. So, and I say that because the manual process around it sometimes is prohibitive. And I can only give an example of a couple of things that's happened to me and to my family, where my husband showed up at the pharmacy to receive a prescription for something we feel he needs, the doctor prescribed, and ultimately it's not covered. And the ability to just know that information right up front so that the doctor could have done the work that was necessary to get the process moving so that he could get the medication and ultimately not get sicker would have been hugely beneficial. So I think today there are some things like a prior authorization that through automation and communication, aligning the stakeholders, as Arlen was saying, in the process will just by nature improve the care. You know, in so many ways, I think there's a third piece, right? And the third piece we can do today is really around sort of the benefits and plan designs that are out there and leveraging that to not only focus on the SickCare. I was talking to a girlfriend of mine's mother yesterday, and she's, 78 years old. And we were talking about how her health plan wanted her to go to the doctors. And they were very, very persistent that she needed to go to her doctors and have a visit. She didn't want to leave the house. And she's generally very healthy, but she didn't want to leave the house. She just, for whatever reason, and to Craig's point, maybe uncomfortable walking or whatever the situation is. And so after lots of creativity, I think on the part of her health plan, they eventually incented her financially to do a wellness visit. Not only did they incentivize her financially to do the wellness visit, but they did it by using technology. In her case, she happens to be computer savvy, so they sent her information and they did, telehealth to deliver a wellness visit, covered that wellness visit, and incented her. And ultimately, they were able to assess her situation, her home life, how she was doing, all because they got creative in the way of delivering the care in a diversity. Arlen said the word earlier. You have to diversify in the way you deliver your care based on what the needs of the individual patient are. So those are some of the things I think we can do now. Like we can understand our patient population now and deliver the care they need now through creative plan designs, creative technology approaches, by automation around some of the core processes like prior authorization. Just really focus on getting patients what they need, when they need it, and how and where they need it. Doesn't solve the problem because, again, it's still probably the sick that'll react the most, but it gets us started on that journey, I think. And I don't know if Arlen or Craig, you guys have anything to add in that way.
I would put a somewhat different spin on that, and that is that what you're talking about in writ large means digital transformation of sick care. So the notion is, some argue that sick care basically has become a data industry that happens to take care of patients. And we're seeing that over and over again in every other industry, whether it's data analytics, artificial intelligence, machine learning, you name it. Now, your comment was, we can do that now. My argument would be, no, we can't. That's a next step. And there are a lot of people that are working on, for example, unique patient identifiers. For example, data interoperability. For example, Oracle Cerner Larry Ellison claiming he wants to create a single universal source of truth, which I think is a pretty hefty lift. But the point is, we are making progress in the digital transformation of sick care. We can't do that now. And it's part of the reason why, if you get handed another clipboard, you're going to kill yourself. So
Well,
we have to be able to, we are making that transformation. But again, that comes with a lot of baggage and a lot of obstacles that people are trying to overcome. I generally believe that we are getting there and things will improve, but it's going to take a while. It's going to take a lot of money. It's going to take the things that I mentioned before to digitally transform SickCare.
yeah, I completely agree. I think though, what is key is some of those tools exist today, and if we could leverage them today, it will absolutely help us in the tomorrow.
You're right. You're right. And telehealth is a good example. So why don't people, it's around. It's been around, actually, it's been around. The patent for the first telemedicine application was in 1924. It's taken over almost 100 years for it to disseminate. And the reason it happened was COVID.
Absolutely.
So it's been around. We have it. Why don't we use it? That has to do with all the reasons that we just discussed. There's a big difference between getting from said to done.
Agreed. Agreed.
I think inertia is the problem there, right? People haven't done it that way, and it's easy just to keep doing the same thing. You follow your policies and procedures, and so Lauren's example was interesting because someone overcame the inertia to make something happen, which was actually quite nice, right?
Yeah, but the problem with that is the person who did it, if they were a healthcare provider, probably didn't get paid to do it, and probably did it in their pajamas after they saw 40 patients that day.
Yeah, it could be. Yeah.
I think just to add my own kind of two thoughts is that where digital has not transformed where I think it can is we have this kind of common tension between large, efficient organizations, right? And personal, warm, inefficient, small organizations, right? And for reasons that I think I understand, but I think we're missing is when we introduce these digital innovations, we almost exclusively push them to these larger organizations to help them get larger. And I think it would be a nice kind of change of paradigm to say, you know what, we're going to maybe, because I think especially with older adults, they like that concept of that one doctor who knows them well, they can walk in. I just hooked up my father-in-law to an oncologist. Oh my God, it was like walking into the Pentagon. There were hallways and hallways and hallways, and it was overwhelming, right? Because they were trying to be efficient, right? But if digital gives an opportunity to be efficient, rather than making efficient organizations, I hate to say this, unfeeling organizations more efficient, why don't we give that power to kind of, I think, providers that people are a little more comfortable with in terms of revealing how they're feeling. Are they worried about falls that they're more willing to walk into rather than have to drive 20 miles to a parking lot to a large building? I think that's a missed opportunity.
I think that's where that alignment comes from too, right? If everybody's incented in the process in the same sort of way, then you.
Right. I would draw the analogy to computers 30 years ago. So we're old enough to remember rooms filled with computers, IBM big machines, and then Apple couldn't talk to Microsoft, and software couldn't talk to other software.
Yes.
Fast forward, now anybody can do anything on an iPhone that has more power than the typical, more computer power than the thing that landed on the moon. I think the same thing will happen. That is, we are continuing to democratize the hardware and the software in health data. The problem we have to overcome is digital literacy and digital dexterity. That means applying the information to actually get things done. And the two biggest barriers are very low rates of digital literacy in doctors and patients. So that's a big barrier. We have to increase the digital IQ of the stakeholders. You just can't expect patients to do this. You have to give them the tools and the incentive.
Absolutely.
And the incentive to be, I mean, you could be cynical, and I think the reason why Microsoft now plays nice with everybody else is greed and self-interest. And I think that, and you could say, well, that's terrible. That's like inequitable capitalism, and I'm sick of that. And it's the original sin of the United States. The fact of the matter is, we're in a capitalist society, and that's usually what drives change. And they're beginning to realize that. So you're going to make a lot more money playing nice together than trying to beat each other up. Forget the fact that it's the right thing to do.
Right.
But that's just my view.
Yeah, that's interesting insight. So I think it goes back to incentives and how do you incentivize these large companies to do better, right? To do right for everybody and still make those massive profits, right? I mean, the Microsoft example fits that exactly, right? If they played nicer, then they don't get marginalized and they make more money. So and that's worked out well for them. So, so how do we do that in healthcare? I don't think any of us have the answer, but it would be interesting to get there. And that sounds like a new thing, right? So, so let's I want to get a few more things out there. So Lauren, you had some other ideas around next steps. You mentioned a few things, but do you want to elaborate a little bit more on some other ideas in the technology space?
Sure, for sure. And I think Arlen just talked about it a little bit. You know, it will take digital transformation. And I think that we've been moving very slow in that space. And I agree with Arlen in that a lot of that is about the inequities in the system and just knowledge gaps in a lot of places. And of course, disparate systems and nobody playing nice together. But I think what we're seeing, at least what I'm seeing, is I'm seeing that the industry is moving in a way that they are looking to first align. And I think that alignment will come through true value-based care, contracting, pay for performance with the right focus on it. And they're doing it not only on the provider, in the practicing provider on the healthcare side, but the provider on the pharmacy side and just collaboration there. But not only that, from a technology perspective, we're starting to see some technologies that are actually connecting the information more real time and starting to share. And in the event, for example, that there's still disparate systems, what we're seeing, at least what I'm seeing in the healthcare space, is more and more people focused on how do we integrate systems, how do we bring together the data from across the care continuum, and not only how do we bring together the data, but how do we use that data today? Because I think that data has been there, but to Arlen's point, it's been 3 months too late. You're not getting information that's really available to you today that you can act on today. And so, you know, what I'm seeing and what I'm hoping is going to continue to be a trend is I'm seeing healthcare providers and technology organizations and innovators come together and say, okay, let's focus on building data, you know, data warehouses, whatever we want to call them, but a centralized access to data. And how do we use AI and ML to actually build insights on top of that and provide decision support upfront, real time, when people need it. And it's really a number of different things. It's not just about data aggregation and integration, but going back to the concept of health assessments, it's not health risk assessments anymore. It's leveraging patient-centric tools to get overall population health information in the hands of the patients and then use that information to drive the decisions real time. And that automation, that I think it's more integration and real-time analytics will really help build true care management solutions. So you keep the healthy by understanding who is healthy and how to care for them, right? And what their risk factors are and really driving, you know, care to them even when they're healthy, and focus on building solutions, providing wellness programs and others to keep them healthy. And then for those that are sick, providing care management solutions, disease management solutions, support around getting them the care that they need, even just overall care management. And all of that will come from the data side, like Arlen's saying. You have to get access to the data, and you have to use that data insightfully to drive us forward. And I don't want to lose sight of what Arlen said, because that's really, really important. And something I hadn't thought of, which is that are our providers able to get that information, internalize it, and use it in their healthcare practice?
I would,
Yeah.
I would draw the analogy of the financial services industry. Highly regulated industry, very data intensive. And I draw the picture, the mental model of a medical ATM machine. So back in the day, just think about it. You can go anywhere in the world with a plastic card and get money.
Exactly.
It's this enormous data interoperability infrastructure. They highly regulated industry, same cyber issues, et cetera, et cetera, et cetera. That's where I think we're going to wind up in some form, not exactly. But you also need to understand that if you've been to your bank lately, the brick and mortar building that you used to go to is no longer there.
Mm-hmm.
And if you want to get a teller to take care of you, it's almost like you have to pay extra to get like a teller. The same thing is going to happen to SickCare. And that will be highly resisted. So that's part of the reason why there's friction in the system moving us toward that. But I think ultimately that's what's going to happen. And it would be like if you went to the bank today and you said, well, how much money do I have in my bank account? And they say, well, we can't tell you, but we can tell you what you had in there a month ago.
That's today's healthcare.
That's today's healthcare.
Yeah, I was gonna make a slightly different comment on what Lauren was saying, and she was talking about aggregating data and providing insights. But I think even more, well, equally important is getting those insights to the people that need it when they need it, right? So I go to the hospital for a general checkup. My doctor comes in with his computer and he looks at all the stuff before he talks to me, so he can understand where I'm at. Like if at that moment he had all the information he needed, not just his view, because his system has, this access to this data, that would be, even better, right? So, So, I mean, that's a tricky problem too. So how do you not only generate good insights that can be actionable, but actually make them actionable by giving them to the people that can take action?
Yeah. Very good point. And that's the key, right? That's the key.
Yeah. So Craig, Lauren mentioned a few things, data aggregation and patient-centered care and all that. I mean, it seems like your organization probably is moving in that direction. Is there anything you want to say about what you're doing in those spaces?
That's actually one of the great aspects of them. And I think, Arlen, aren't you going to a conference about this in a couple weeks, on AI and healthcare? All right. So merging AI and VR really gives us an opportunity to really personalize each person's experience with the Gatebetter, right? So we can actually watch how the person performs in that virtual reality environment, and then based on best practices and maximizing efficacy, we can actually adjust the challenges, both motor and cognitive, we give the person, right, to increase the effect of the intervention, right? Whether it's something as simple as they're struggling more on the left or the right, so we give them, stronger challenges on the left. They have more cognitive issues, so we increase the cognitive challenge. All these things are kind of open and kind of fulfill some of the things that Lauren and Arlen have talked about in terms of the vision for healthcare. It's right here, kind of in this technology.
I would also point out that we have to solve this issue of the gap between the data and the doctor. There is simply, it's impossible for any individual. The doubling time of scientific and medical information is 43 days. It is physically impossible for me to process that. So as a healthcare provider, so if I'm looking at you in the eyeballs in an examining room and I'm trying to figure out what's going on, I don't need big data. I don't need streamed data. I need the least amount of the most important actionable information at the point of care.
Absolutely.
Yes. Yeah, the big data can help get that, but you don't need the big data. That's a really good
I don't
point.
want the big data. And if you come at me with a solution that requires it, I'm not going to do it.
Yeah, it has to be easy for the physician as part of his process to get that information and move quickly, right? Because he's got many things to do, he or she, many things to do. And you know, sifting through data can't be one of them. I understand 100%. Okay, well, I think we've covered most of what I wanted to cover in this session. Jill, do we have any questions coming from the audience? Anything that we can address?
None to address. It's been pretty cool. Just our listeners. Lots of listeners, but no questions.
Okay, great. Thank you. So I guess the final point I'd like to make is just a call out to everyone. I think, Arlen, you mentioned this earlier on, and I want to reiterate is for this to change, we're going to have to take action, right? So we as individuals have to want it to change. We have to push for the change, and there's many ways that we can do that. You know, like I say, one is you can take personal initiative and use your time, but the other is you can take political initiative and use your vote. Either one, regardless of your position, right? Either one can help us move forward. So that's my request for the people here.
Right. I also think it's important for patients. So at the end of the day, this conversation is about how do I take care of my elderly mother, or how does my elderly mother take care of herself, or it's just about AgeTech. And an increasing aging population with a demand for services. So let's talk about what can a patient in the sandwich generation, my guess is everyone on this panel has been in this situation. I have. My mother was in a nursing home, et cetera, lived 1,600 miles away. My sister fortunately lived near there, and we dealt with the issues. And my guess is in some way, shape, or form, most of us have come across that. So what should a patient or the relative or a loved one of a patient do? What would you suggest they do given the reality of today? So Craig, from the standpoint of your solution, what are you seeing in terms of adoption? And because after all, in a lot of instances, the customer is not the patient. The customer is the loved one who is looking for peace of mind. You are selling peace of mind. So what are the issues?
I mean, to understand the complexity of healthcare, as Arlen, you know, right? A very trusted advisor to Gatebetter told us, when you sold to one healthcare system, you sold to one healthcare system. Right? There are literally hundreds, if not thousands, of healthcare systems around the U.S. So it's difficult to paint a broad brush. I would say there are those that really embrace value-based care, right? They are truly up to the CEO. They are truly interested in improving the health of their community, and they will kind of put money where their mouth is. There are other healthcare systems that are still deeply embedded in that fee-for-service world, right? Which is very dependent, Arlen's indicated, very dependent on SickCare. They don't make any money off healthcare, right? So they're not vested or interested in technology that makes their patients better unless their patients are already sick, right? So, you know, I think we continue to strengthen our relationships with those value-based care systems, right? We learn to work within the existing system for now, right? And we also acknowledge that, one of the values of digital is we can give people some ability to control their data, right? And their true healthcare. So we're slowly considering pivoting over to a home-based system, right? Where people will have that freedom and access to data, right? And then they can share, right? One nice thing about technology is they can share that data with that doctor, but sharing that data with that doctor in more immediate terms, right? Because it's only one machine to one doctor, right? It's not an enormous big data regime, and we can parse it down to the data that the doctor needs most.
And that brings up another subject, which is who owns the data. So if I believe that patients, and this gets to, so what can a patient do to kind of understand this brave new world? First of all, they need to educate themselves about, they don't need to be a data scientist, obviously, but they need to understand and have some basic knowledge of what's happening in terms of artificial intelligence. Is your doctor using it? How do you know it's telling them the right thing? What are my rights if something goes wrong, et cetera, et cetera, et cetera. And I believe that patients eventually will own their data, and that ownership means they have intellectual property rights to an asset. So instead of giving your data away now, nobody's putting a gun to your head to give this stuff on social media. You're just doing it. But you're exchanging that information to the benefit of the company, because that's how they're making money, through insights and advertising. So it's basically data for dollars, but you don't get the money. So I think eventually patients are going to be a lot more proactive in saying, you know what? I own my data. And what's more, I have a pretty rare disease, which makes it even more valuable for a med tech or a pharma company. And I'm going to monetize that data, just like any corporation would with intellectual property. I could rent it. That is, I could create a license for you to use it. I could sell it to you. I could create a public auction where I can exchange and buy and sell. So I think this whole evolution, that's what's going to happen the next. This is how I see the next. That this whole data infrastructure will become very patient-centric. And that means if you want to invest in Bitcoin, knock yourself out, but you better know something about blockchain. Otherwise, just read the headline today. Same thing's going to happen, I think, in digital health data where patients own it. And so that means you're going to have to get up to speed and increase your digital IQ.
And I would just add to that, I think it starts simple, right? It's about the patients now asking questions and being the consumer of healthcare. Really own your process. At least for me, I happen to agree with Arlen, and I'm like, this is one area that I am super passionate about. I think patients should own their healthcare. They should understand what's happening for them. They should have one place they can go to and see every doctor they saw, every prescription, every diagnosis, every, everything in one place. But it takes the patients asking for it. It takes the patients care in understanding their care in the same way that they're consumers in other areas. And so I think right now my call to action for patients are ask questions, log into your patient portals, get information from your payers and plans about what's happening in your healthcare so that you're informed, and start demanding to be part of the process. That's
That's a good point.
Yeah, 40% of patients actually use their patient portal. 5 years ago, it was 10%. So we're beginning to see an uptick in people doing that. But one recent caveat was that, and this particularly has to do with patient portal access to minors. So if you're a guardian of a minor, and let's say there are issues that you don't want to divulge to your parent or your guardian, whether it's sexual issues or behavioral health issues or depression issues or drug and alcohol or whatever, then guardians can, in instances, access information that the child, that is someone under 18, does not want them to see. So there are patient portal issues, but over the long run, I believe the benefits far outweigh the cons.
Just have to get there.
Yeah, that makes sense. Well, we're rapidly approaching the end of time, and we could probably talk about this for hours. I know, Arlen, you're very passionate about it. Lauren, we've discussed it many times, and you're passionate. Craig, I mean, you're in the middle of this, so of course we could talk about it forever. I think now is a good time to wrap up. This is a really enjoyable conversation, really insightful, and I really appreciate the three of you jumping on and talking to us. And also I appreciate the audience for taking the time to listen to what we have to say.
Thanks for hosting.
Yeah, you're welcome. Thanks, everyone. Have a great rest of your day. Bye.
Yeah.